You've been calling it low testosterone, the difficulty getting or maintaining firmness, the reduced response, the anxiety before intimacy. You've explained it as hormones, as age catching up, as something that testosterone replacement would fix. The American Heart Association has a different word for it, and that word connects directly to your arteries. A 2013 study published in the journal Actas Urológicas Españolas analyzed carotid ultrasounds in 44 men presenting with erectile difficulty. 25% had measurable atherosclerotic plaques in their carotid arteries, the arteries that supply blood to your brain. The control group, men without erectile issues, had 0 plaques. And arterial wall thickness was 0.71 mm versus 0.54 mm in controls. That's 31% thicker. In arteries that haven't produced chest pain yet. In men who had no idea their cardiovascular system was already compromised. Medical research identified 4 specific vascular pathways that produce erectile difficulty in men under 50. 4 mechanisms that operate silently for years, sometimes decades, before the symptom appears. Reason 3 is the one most men discover accidentally, during a test ordered for something completely unrelated. And reason 4 explains why the symptom appeared suddenly, when the process had been building for years. We'll go through all 4. But I'm not starting with the obvious one. I'm starting with the one that urologists see most often in men who thought their testosterone was the problem, who spent months on replacement therapy that did nothing. And reason 4 is the one that connects your morning erections to something your cardiologist should have been monitoring, but probably wasn't. Reason number 1, endothelial dysfunction. Your arteries stopped producing the signal. Think about the last time you had difficulty achieving firmness. The arousal was there, the stimulation was there, but the physical response didn't follow. You blamed stress, or fatigue, or age. When was the last time you had a firm morning erection? If it's been more than a week, that's already a signal. An erection requires one specific chemical, nitric oxide. It's produced by the endothelial cells, the single cell layer lining every artery in your body. When those cells are healthy, they release nitric oxide in response to arousal signals. Nitric oxide relaxes smooth muscle in penile arteries. Blood flows in, pressure increases, firmness follows. When endothelial cells are damaged by inflammation, by oxidative stress, by accumulated lipids, they stop producing adequate nitric oxide. The arousal signal arrives, the nerve impulse fires. But the chemical messenger that relaxes the arterial smooth muscle never releases in sufficient quantity. The arteries don't dilate. Blood flow remains restricted. The erection doesn't form. A 2022 study published in Biomedicines documented that endothelial dysfunction, measured as reduced flow-mediated dilation, was present in 87% of men with arteriogenic erectile difficulty. The endothelial cells that line the penile arteries are the same cells that line your coronary arteries, the same cells that line your carotid arteries. When they fail in one location, they're failing everywhere. But the smaller arteries show symptoms first. The penis has arteries 1.2 meters in diameter. The coronary arteries are 3 to 4 millimeters. Same disease process, different timeline for symptoms. Endothelial function can be measured with a flow-mediated dilation test, a non-invasive ultrasound that checks how well your arteries dilate in response to increased blood flow. If the test shows dysfunction, the pathway is clear. Reduce inflammation, improve lipid profile, control blood pressure. The endothelial cells can recover, but they need the insults that damaged them to stop. That's reason 1, A chemical messenger your arteries stopped producing. Reason 2 is structural, and it's already measurable on a standard ultrasound, if your doctor knew to look. Reason number 2, arterial wall thickening. The plaque you can't feel yet. The erection starts, then stops, or takes longer to achieve than it used to, or requires more direct stimulation than before. You don't feel chest pain. You don't have shortness of breath. You pass your annual physical, but the symptom persists. Has your doctor ever ordered a carotid ultrasound? If not, they've never measured your arterial wall thickness. And that thickness predicts your cardiovascular risk more accurately than cholesterol alone. The intima-media thickness, the combined thickness of the two innermost layers of your arterial wall, increases when lipids accumulate beneath the endothelial surface. This is the pre-plaque stage. The artery hasn't stenosed yet. Blood flow hasn't restricted enough to trigger angina, but the wall is already thicker than it should be. That 2013 Spanish study I mentioned earlier, the one that found plaques in 25% of men with erectile difficulty, also measured intima-media thickness. The men with ED had arterial walls averaging 0.7 mm. The control group averaged 0.5 m. That's a 31% difference. And a 0.7 mm or measurement puts you in a higher cardiovascular risk category, even if you have no cardiac symptoms. The multi-ethnic study of atherosclerosis, MESA, followed 162 men for 9.4 years. Men who developed erectile difficulty had a 39% prevalence of carotid plaque score, TRCT2, at baseline, compared to 21.1% in men who remained symptom-free. The plaque was already there, years before the erectile symptom appeared, years before any chest pain. The penis reported the problem first because its arteries are smaller. A plaque burden that restricts 20% of flow in a 1 mm penile artery is subclinical in a 3 mm coronary artery. But the disease process is identical and progressive. Request a carotid ultrasound. It's non-invasive. It takes 15 minutes. It measures intima-media thickness and identifies plaques. If your thickness is elevated or plaques are present, you need aggressive lipid management, not just dietary changes. Statins. LDL under 70 if plaques are present. The goal is stabilization, preventing plaque progression, because regression requires years of perfect lipid control. 2 reasons, both vascular, both measurable. Reason 3 is metabolic, and it's the one that produces the fastest progression, from normal function to complete dysfunction, in under 5 years. Reason number 3, chronic inflammation, the fire you can't see. Your blood tests come back normal. Cholesterol is acceptable. Blood pressure is controlled. Fasting glucose is under 100. But erectile function continues to decline, slowly, steadily, with no obvious explanation. Has your doctor ever ordered a high-sensitivity C-reactive protein test? If your hs-CRP is above 2.0 mg/L, you have chronic systemic inflammation, and it's damaging your endothelium right now. Chronic low-grade inflammation, the kind produced by visceral fat, poor diet, sedentary behavior, chronic stress, releases inflammatory cytokines that circulate through your bloodstream. These cytokines damage endothelial cells directly. They reduce nitric oxide bioavailability. They promote oxidative stress. They accelerate atherosclerotic plaque formation. A 2022 meta-analysis published in the World Journal of Men's Health analyzed 57 studies with 7,312 men. They found a direct correlation between inflammatory markers, specifically hs-CRP and IL-6, and erectile dysfunction severity. Higher inflammation predicted worse erectile function. Independent of age, independent of cholesterol, independent of blood pressure. The mechanism is cumulative. Every day of elevated inflammatory markers is another day of endothelial damage. The cells lining your penile arteries are exposed to inflammatory cytokines 24 hours a day. They're not recovering overnight. They're accumulating damage. And when enough cells lose their ability to produce nitric oxide, the erectile response fails. Not suddenly, gradually, over months or years, until the threshold is crossed and the symptom becomes undeniable. Measure inflammation. Request hs-CRP, IL-6, and fibrinogen. If elevated, the fix is multi-pronged. Reduce visceral fat, the inflammatory fat around your organs. Adopt an anti-inflammatory diet, Mediterranean pattern, high omega-3. Increase physical activity, 150 minutes moderate intensity per week minimum. Manage chronic stress. The inflammation didn't appear overnight. It won't resolve overnight. But endothelial cells can regenerate when the inflammatory insult is removed. 3 reasons, all produced by processes that were invisible while they were building. Reason 4 is the one most men refuse to believe is connected, because it happens at night while they're sleeping. Reason number 4, arterial stiffness, the loss of elasticity you didn't feel. You wake up, no morning erection, again. You used to have them reliably, now they're rare, or absent. You assumed it was testosterone, but your total testosterone came back normal. Free testosterone normal, LH and FSH normal. The hormone axis is functioning. But the spontaneous nocturnal erections, the ones that happen during REM sleep without conscious arousal, have stopped. When was the last time you woke up with a firm erection? If it's been more than 2 weeks, your arteries have lost compliance, and that loss predicts cardiovascular events more accurately than a standard lipid panel. Arterial stiffness, measured as reduced distensibility, is the loss of elastic recoil in arterial walls. Healthy arteries expand when blood pressure increases during systole, then recoil during diastole. This expansion-recoil cycle is essential for penile erections. When penile arteries stiffen, they lose the ability to expand adequately in response to nitric oxide signals. Blood inflow is restricted not by plaque stenosis, but by mechanical rigidity of the arterial wall itself. The MESA study I mentioned earlier also measured arterial distensibility. Men who developed erectile dysfunction had significantly reduced carotid distensibility at baseline, years before symptoms appeared. 34.6% of men with ED had distensibility below the 25th percentile, compared to 17.1% of symptom-free men. And aortic distensibility showed the same pattern, 34.2% versus 18.7%. Morning erections are a test of arterial compliance. They occur during REM sleep when parasympathetic nervous system activity increases. Nitric oxide is released. Healthy, compliant arteries dilate. The erection forms. But stiff arteries, arteries that have lost elasticity due to collagen cross-linking, advanced glycation end products, calcium deposition, cannot expand sufficiently. The nitric oxide signal arrives. The smooth muscle relaxes. But the arterial wall itself won't yield. The erection doesn't form. Not because of hormones, not because of psychological factors, because the arteries have become mechanically incapable of dilation. Arterial stiffness can be measured with pulse wave velocity testing. If stiffness is elevated, the interventions are the same ones that reduce cardiovascular risk. Blood pressure control, eliminate smoking, reduce advanced glycation end products, increase aerobic exercise. The stiffening process took years. Reversal takes years. But compliance can improve. 4 reasons. All of them vascular, all of them measurable, none of them about testosterone. And here is the finding that changes how you understand what erectile difficulty actually signals. Your erectile dysfunction is not a sexual problem. It's an early warning system. A 2022 systematic review published in Biomedicines analyzed the relationship between erectile dysfunction and cardiovascular disease. They found that 65% of men experienced erectile symptoms before any cardiovascular event. The average time interval between the first erectile symptom and a cardiac event was 3 years. The arteries in your penis are 1 to 2 millimeters in diameter. The coronary arteries that supply your heart are 3 to 4 millimeters. Same disease process: endothelial dysfunction, plaque accumulation, inflammation, stiffening. But the smaller arteries show symptoms first. A plaque burden that restricts 30% of blood flow in a 1 millimeter penile artery may only restrict 10–15% in a 3 millimeter coronary artery. Not enough to trigger chest pain, not enough to show up on a stress test, but enough to prevent an erection. Your erectile difficulty is not the problem, it's the signal, the canary in the coal mine. The first symptom of a vascular disease process that is already operating in every artery in your body, including the arteries that supply your heart and your brain. That is not a comfortable finding, but it is a life-saving one, because you now have a 3-year window, on average, between the first erectile symptom and a potential cardiac event. A window to measure the underlying vascular disease, a window to intervene, a window to prevent the progression from subclinical arterial disease to a clinical cardiovascular event. Here is what the research gives you: not a diagnosis, a map. The 4 pathways documented the specific mechanisms producing the symptom, which means the interventions that target those mechanisms can prevent progression, and in many cases, produce measurable improvement. The endothelial cells that stopped producing nitric oxide can recover when inflammation is controlled and lipids are optimized. The arterial walls that thickened can stabilize and, in some cases, regress with aggressive lipid management. The chronic inflammation that damaged your endothelium can be reduced with dietary changes, weight loss, exercise, stress management. The arterial stiffness that prevented dilation can improve with blood pressure control, smoking cessation, aerobic conditioning. This is not fast. The vascular damage accumulated over years. Recovery takes time, months to years depending on severity. But the mechanisms that produced the dysfunction are not irreversible. They are modifiable, responsive to intervention. And they have been waiting the entire time you've been blaming low testosterone for the correct diagnosis and the correct treatment approach. The erectile dysfunction that brought you to this video is not the end point. It's the beginning. The first detectable signal of a vascular disease process that you now have time to address, before it produces a cardiac event, before it produces a stroke. While intervention can still change the trajectory, the symptom that embarrassed you may have just saved your life. Low testosterone is what you call it when you don't understand the vascular mechanism. The cardiovascular research calls it early-stage arterial disease. The urology literature calls it a sentinel event. And that arterial disease, the one that built the symptom you've been living with, is measurable, treatable, and reversible if addressed before it progresses to a clinical cardiac event. That is not a comfortable finding. It is a life-saving one. Leave a comment. Which of the 4 mechanisms did you recognize in your own situation? And which test had you never heard of before? because the next video documents the exact testing protocol cardiologists use to screen for subclinical vascular disease in men with ED, what tests to request, what the results mean, and the intervention thresholds that determine whether you need immediate treatment or can manage with lifestyle changes alone. Always consult your doctor. This video is for educational purposes only.